Hello, everyone. Welcome. Thank you all so much for joining us today. My name is Ariana Ali. I'm a third year medical student at the George Washington University School of Medicine and Health Sciences here in Washington, D.C. I am also one of the student leaders at our local SAFE chapter and a proud member of SAFE's National Board of Directors. For those of you new to SAFE, the acronym stands for Scrubs Addressing the Firearm Epidemic, and you can learn a lot more about the work SAFE does by visiting StandSAFE.org. Allison will put a link in the chat. Before we get started, I would like for everyone to drop in the chat where you're joining from. It's always super meaningful to see how far and wide SAFE reaches across the country. A little bit about me and where I'm from. I'm from South Florida, and I initially became involved in the firearm injury prevention movement after surviving the Marjorie Stoneman Douglas high school shooting in Parkland, Florida back in 2018. I'm really, really grateful to be having this conversation with you guys today and spending the next hour talking to Dr. Ted Corbin and Dr. James Bigham about the importance of incorporating trauma-informed care practice into all firearm injury prevention work, as well as the critical need to become culturally competent when we're talking about firearms. The format of our event this evening will be a guided Q&A session with Drs. Bigham and Dr. Corbin. And while I do have some questions lined up, SAFE would also like to give you guys the opportunity to submit questions in the chat as things come up for you and that you would like for us to respond to. And we'll get to your questions during the last 20 minutes or so of our hour together. So just to set the stage a bit, this evening's content will include some information about what is trauma-informed care and how we can operate from that space in our respective disciplines, how we can approach gun ownership in this country, how critical it is to understand lived experiences upstream and downstream the spectrum of care, and examples of culturally competent language. So now I'll introduce our speakers for this evening. Dr. James Bigham, he is the clinical professor in the Department of Family Medicine and Community Health at the University of Wisconsin School of Medicine and Public Health. Dr. Bigham serves as the vice chair of the National Board of Directors for SAFE. And Dr. Ted Corbin is the Carol A. and Leo M. Henikoff, MD, Presidential Professor and Chairperson for the Department of Emergency Medicine at Rush University Medical Center. He also serves on the National Board of Directors for SAFE. Thank you both for agreeing to join us this evening for one of SAFE's two national events this year. So let's start with the first question. Dr. Corbin, when we hear of trauma-informed care, what does that mean exactly and how do you apply it?
Thank you, Ariana. I'm really happy to have this time and space, um, and for the opportunity to be a part of the conversation and for the work that SAFE continues to lead in this space. As an emergency medicine physician, I approach this issue through a clinical lens, but also through a human one. We know that firearm injury is not something that we encounter in theory. It's something we see in real time, often at its most devastating. And what that has taught me is that this is not just about treatment, it's about prevention, trust, and how we show up for patients and communities in moments that matter most. Much of what I'll share today sits at the intersection of trauma-informed care, cultural humility, and science. And because it is only when those come together that we begin to see meaningful, sustained impact. When we talk about trauma-informed care, we're really talking about a shift in mindset from asking what's wrong with this patient to really asking what's happened. And at the core, trauma-informed care recognizes that many of the patients we serve, particularly those I would say impacted by violence, carry histories of trauma that shape how they experience illness, how they experience healthcare, and also how they experience us as providers. And in practice, that means a few things. It means creating a sense of safety, both physically and emotionally. It means approaching patients with empathy and without judgment, and being mindful of how our words, our tone, and even the environment can either build trust or reinforce harm. And it means giving patients a sense of control and partnership and decision making in their care, especially in moments when they may feel most vulnerable. And we know, and especially in the emergency department, it's particularly important. We often meet patients on some of the worst days of their lives, and a trauma-informed approach doesn't slow us down. It actually allows us to connect more effectively and make better clinical decisions and ultimately deliver human-centered care.
Thank you, Dr. Corbin. Building off of what you said about approaching patients, Dr. Bigham, our next question is, how do you approach our patients? And does our approach with patients change based on our own identities and experiences with trauma?
Yeah, thanks. That's a great question. I just want to say good evening. It's great to be with you all. Thanks for joining us. Ted, I loved your answer. I loved your answer and that it hit all the things. We show up in the clinical spaces as our best selves when our patients sometimes are in their most vulnerable moments, and we want to make a connection. We want to connect and build trust so we can actually do the important work that we're called to do, which is healing. And when I think about this, I often wonder, you know, not just what's the patient's backstory before they come in, their lived experience before they come in and they see me, but I have to also inquire about my own. And when I actually take a moment to pause and consider myself and my own preferences or my own thoughts, I have to lay bare that I might have some biases. And I might be coming at something with a conclusion that seems like it fits with my own lens, but there might be more to the story. And so often, I think before I even get into the exam room or into the encounter with the patient, I want to take a moment and do my own pulse check and make sure I recognize I have privilege and I have maybe a perspective that may not align with exactly what's been going on for the patient that I'm going to be working with. And so when I do that, it's a moment of like kind of a deep exhale. And then I allow the patient to teach me about themselves, because ultimately the patient's going to help us understand what their needs are. And if we ask the right questions with the right posture and we maintain an open mind, it's going to actually help us provide the best possible care. Appreciating someone maybe acting in a certain way because of a lived experience or past trauma helps me not just play a tape in my head that, oh, this means that this lack of eye contact means they don't trust me or vice versa, or even appreciating that they might live in an environment where their access to firearms means something different than the place where I live. And so important to make sure I'm making space for the patient and not too quickly just assuming I know what's going on. And having that trauma informed lens is really helpful when we talk about firearms, but honestly, it can be helpful with vaccine hesitancy. It can be helpful with all sorts of different encounters that we have with patients because past experiences are what patients bring with them into the exam room or into our clinical spaces. And it's important we make room for those.
Thank you. I really do like what you said about the application of trauma-informed care. It really extends into pretty much everything in the clinical space. And I really, really do like your perspective about approaching patients also with your identity in mind. And that really does lead into our next question for Dr. Corbin. How has your identity and lived experience as a Black male professional shaped the way you approach trauma-informed care?
Yeah, James couldn't have, it says so much, and I appreciate that in a big way. And for me, trauma-informed care is it's not just a clinical framework. It's also personal, and I think it's personal for many of us in so many ways. And as a Black man, I'm very aware that my patients, many of the patients that I care for, particularly those impacted by violence or have some experience may carry experiences of trauma, mistrust, marginalization, and that shapes how they engage with the healthcare system and me. And I also recognize that I bring my own lived experiences to those encounters, having as many of us do, our biases, but then also recognizing that patients may have biases towards us. Others have had biases towards us, and what that experience has taught us is really, really important. What Trauma Informed Cares asks of me, the way I see it, is to be both self-aware and intentional. And you'll hear me say this often, but it's also leading with humility, being able to listen closely, and also to ensure that every patient that I encounter feels seen, respected, and safe. And it's really about recognizing that trust is not assumed. It's built and often in very small moments. And in many ways, that alignment between lived experience and clinical practice allows me to connect more authentically and care more effectively for patients. There's also these aspects of racial trauma that that also come into the room as well. And so recognizing that also has its own bearings on us as providers and on and our patients. And when we think about violence in the big scheme of things and how some of our disenfranchised communities have had to rely on themselves because of some mistrust with the police. That's not everyone, but there are some folks that really do not feel protected by the police. And what that leads to is those patients or those people getting guns themselves to protect themselves, leading down to a path of hurting others or in turn getting hurt that leads to either death or incarceration.
And I just want to say I love what you said about trust is something that isn't just assumed. It's something we have to earn.
Absolutely.
And so there's work we do. It's this really powerful human work to actually cultivate that trust. And I think when I talk to my medical students, that's the magic. The magic is how do we cultivate that trust? And that's at the heart of all this, right?
Yeah. And what's interesting, James, is that we already have a little bit of an in because patients are coming to us.
Yeah, so it helps that they're already leaned in and they're already hopefully at least somewhat bought in. Although maybe in the emergency department it's a bit different because sometimes things happen and they're brought to you,
Yeah.
right? So yeah,
There's that too.
yeah.
I think you touched on a lot of great things, and I think the example that you gave especially really speaks to things like cycles of violence in communities. So I really do appreciate your response, Dr. Corbin. My next question is for you, Dr. Bigham. What is the goal of these conversations when our patients are brought to us when we bring up firearms?
Yeah, at the risk of giving you a two-word response, it's harm reduction. And I could probably mic drop, right? Mic drop. So there's a lot of things we bring into these conversations, but if we frame it as harm reduction, we can find a way to align with our patients and actually find some common ground. I find that when I'm talking to patients and I share with them that, hey, we're on the same team here, we're on the team of let's keep you and your family safe. Let's work together to make sure that there isn't unauthorized access to a firearm so that someone you love isn't injured with your firearm. There's a lot of buy-in there because that's the sort of thing that the people actually feel like, yeah, that's what I want too. And so in many ways it's trying to make sure that as I'm approaching it, I'm mindful not just about my why. The why matters. This is the number one cause of death for kids. The why matters, but the how matters more. And so the posture that I'm going to come at this as I'm talking to patients is really important and the how and really trying to help them understand that we're framing this in a way that is about caring about them. And I'll say things like, hey, because I care about you, I will fully show all of my cards. Because I care about you, I want to reduce the risk of harm for your family. And I don't say you should or shouldn't have anything. Like if they should or shouldn't own something, that's a choice they've made. It's a personal choice. What I want to do is recognize when someone has access to a firearm, they've changed their risk stratification. They've increased the risk of a firearm related harm. And so that I want to engage in a discussion about how do we close the gap? How do we try to minimize the harm, even incrementally, the risk of harm incrementally, until we get as close to zero as possible?
Thank you. I really like the nuance and the way you framed this conversation. I feel like it's super important to be on the same team as your patient, and I think framing it that way really makes it feel like it's a team effort and not you against the person. My next question, Dr. Corbin, can you speak to whether a more culturally competent approach is actually helping to reduce violence? And can you share any perspective data on that reduction of homicide in the last 2 years?
Yes, it's an important question, and I think I'm gonna have to answer it in two parts. So first, trauma-informed and culturally responsive care are foundational, but they're not standalone solutions to violence. Violence, as we know, we all know, it's a complex public health issue, and it's influenced by social, economic, and structural factors, right? And what these approaches do is improve how we engage patients, building trust, increasing follow through, and connecting individuals to resources that can reduce risk over time, right? The other part is when we look at broader trends, there is cautious optimism, and I want to underline cautious optimism, and that after a significant rise during the pandemic that we saw in many U.S. cities, there's been meaningful declines in homicides over the past 2 years. In some cases, on the order of double-digit percentages decrease year over year. And that reflects a combination of factors. It's community-based interventions, it's public health strategies, cross-sector collaboration, as well as hospital-based, community-based intervention programs as well. And so while we can't attribute those changes to any single intervention, trauma-informed, culturally competent care is an important piece of a larger coordinated approach to all of it.
Yeah, I think that's a great point, Ted, that if we don't even have the right kind of posture as we're doing these things, the best designed intervention, if it isn't actually going to be culturally responsive and have that underpinning of being, trauma informed, it may not play out.
Right.
It may not even have a chance to succeed even at the outset.
You're absolutely right.
Thank you for your response. I think that really frames it on such a large perspective on like a community level, but bringing it down to an individual level, Dr. Bingham, we know firearm ownership is a very deeply personal topic. Some people feel very private about this. It can be a little stigmatized to talk about. So, how do you approach these conversations about guns with patients on an individual level that promotes safety without making someone feel judged or stigmatized?
Yeah, that's a real challenge. That's the art of these human interactions. And I think if I was going to choose a posture to encourage other folks to embrace, it's one of curiosity. I think if we can come towards this with the best of intentions for our patients, assuming the best of them and for them, and we can just come with curiosity and ask just natural questions like, hey, tell me about if you have access to firearms, and then what do you use those for? And we'll get into more of the language in a bit, but just having that sort of, I'm okay with whatever you're going to say in this moment because it's not about your answer as much as about us connecting and having a chance to understand the work we might be able to do together to reduce the risk of harm. And I think sometimes we don't know the question we ask until we hear a patient's response back. And so we may have to practice this a bit. We have to practice a bit of how we approach this. And I often will retell a story of when I worked with a medical student. I always try to encourage them to give it a try to just ask about firearms. And I had a patient once ask a student once asked a patient, where they kept their firearm, and the patient looked at them like, I'm not telling you. And I called a timeout, and I was like, I think the question we want to ask is not where is it, because we're not coming for it. I'm not coming for your gun. It's not where, it's actually how are you storing it? And the how is about, is it secure? The how is about, is it going to be inaccessible to unauthorized users? And so at some level, it's feeling out the patient and kind of their own preferences and understanding their why. I can imagine if I'm caring for an individual who lives in a place where they don't feel safe moment to moment, or maybe they're in a relationship where they don't feel safe, and maybe they've had a bit of an issue in the past with a criminal record, and so they can't legally own a gun. Well, if someone has access to a firearm they shouldn't have, they may not want to tell me about that as their doctor, right? For fear of reprisal. And I make it clear I am not the police. I make it clear I am nothing but their provider who cares about them and just wants to make sure that everything we're doing moment to moment is going to be about promotion of health, harm reduction. It's important that I also talk about the backstory, the why the person feels they need the firearm at all times. We should be talking about those things. And are there resources that we could actually try to rally around that person to make sure that they aren't moment to moment living in fear of their life? And that comes back to some of these bigger structural things, historical things. And I think it's important for us to remember that there's a lot of history here. And a lot of the history didn't play out the way that a lot of us were taught it played out. And we're seeing the ramifications now. And so I think if we're going to move towards a cure, we have to have a moment of reckoning. And so I think we need to just be mindful of the fact that there's some systemic things historically, like systemic racism and the way that urban centers were redlined in this country that have actually made an impact. It's not the only reason, but boy, it's a big contributor. And those are things I think as we think about this, we got to think more globally and really pan out and recognize that with curiosity, we can learn more. And also hopefully we can maybe expand our own worldview because it's not such a small thing. This is a really big topic. Guns in America, it's not just one thing. It's not just one way of owning a firearm. It's many things. It's many different types of owners. One thing that's interesting to me is the folks who are currently the fastest growing population of new firearm owners are Black females. That tells you something. And it leads me to that curious spirit of, oh, I wonder why. I'd like to learn more, not in a judgmental way, but I'd like to learn more. And then I want to actually dig in and make sure that the person who has purchased a firearm has thought about what they can do to reduce risk of harms. And so we might talk about things actually like getting training to use the firearm, which I think for some of our friends and colleagues in this space, in the gun violence prevention space and the firearm injury prevention space, saying things like I counseled my patient on taking a course on how to safely handle their firearm and operate their firearm. Some of them may not like that, but I think that's actually cultural humility. The patient has decided to own the firearm. We should make sure they're going to be able to do so responsibly in a way that's not going to lead to harm for themselves or their family. It was a big answer to a small question. Or maybe it was probably a big question. It was a big question.
That was a big question. It was a great answer. And it's so important, James, because I think the other piece that we feel an obligation is the safety piece, is just it's really about safety because I think just as you mentioned, because of the systemic challenges, it's there are so many layers to the folks that we care for that it's not in it might and often isn't intentional that the gun is not safely stored. So I think that's part of our work. I know that's part of our work.
Yeah, I mean, it is a very, very hard thing to talk about. And I think you really touched on the fact that it goes beyond just asking the patient, hey, do you have a gun? Like, there are just so many things to keep in mind and be mindful of, even when you're approaching the patient. And I just think having that underlying openness and kind of setting the stage will bridge that trust and allow you to
I,
have that
it
conversation.
should also be said that patients may not tell us the truth.
That's also true.
And so I tell my learners all the time, the patient might lie to you. And they're like, what? I'm like, yeah, they may lie to you. It's okay. It's okay. We're going to hold space for them. We're going to create an environment where it's okay if today wasn't the day for them to be forthcoming. We're going to make sure the space is a safe one so that when they're ready to share, we're here. So we're going to leave it in a way that they know that we're not going to judge, we're going to be open, and when they're ready to talk about it, we can go there.
I love that. Also, I feel like just so many people don't even know how to talk about it. And as a third year medical student, I think a lot of the learning is also just how to talk about things, how to ask patient things. So when you told that story about your medical student, I kind of laughed a little bit because I was like, I mean, that's just the third year experience kind of wrapped up. My next question for you, Dr. Corbin, is can you share your thoughts on how science intersects with firearm injury?
Yeah, that's science without question, hands down, is essential. It gives us the framework to move from anecdote to action. Uh, Firearm injury is a public health issue, and like any other, it benefits from rigorous data, epidemiology, and implementation science. And we can study patterns of injury, we can identify risk factors, we can evaluate interventions and scale what works. And so the example is we have strong evidence that safe storage practices, as we were just talking about, reduces unintentional injury and suicides. That's a fact. Science told us that. And then growing evidence around hospital and community-based violence intervention programs is growing. Um, and then science also helps depoliticize the conversation. And it allows us to focus on outcomes, what keeps people safe, what reduces harm, and and to build strategies that are evidence informed and measurable.
Yeah, I think I love this answer. I think there's a risk also if we go with anecdote or with kind of like our own gut check that we could, without any evidence behind it, disenfranchise somebody.
Or
Or
hurts.
we could act in a way that we think, oh, this is the right way, or we talk around things or we avoid the intervention because we assume it's going to be this. Or this happens with talking about extreme risk protection orders. People say, well, then no one's ever going to talk to you about having a gun if they know you're going to take it away from them. And actually, there's some data when you survey people that they're pretty okay talking about it. And when they're in a crisis, they might want their gun out of their house or to have someone else hold it. And so this isn't one homogenous culture here. It's not a monolith. It's a whole lot of different people. It's hundreds of millions of people in this country, who own firearms, or 110 million people in this country own firearms, and half of homes, give or take, have access to them. And so it's going to look a lot of different ways. And so we need a lot of data because we want to make sure we get it right. And suicide prevention is going to look different than homicide in an urban space or things like that. And so we need to have a way to actually have some good data, or intimate partner violence, et cetera. So have the data for each of these things because it's pretty nuanced. And the stakes, the scope of this is so high, there's no reason we shouldn't be spending money on this as far as a public health intervention. I mean, it's up there with motor vehicle crashes for deaths in America. We spend a lot of money doing research on motor vehicles. And so it's there. I think sometimes our own culture and the politics of the day sometimes are what cloud our vision on this. And it's important for us as clinicians to move in and say, no, this squarely is science. This is part of medicine and public health. And we got to go there.
Yeah, I definitely think having the evidence and sort of science to back up certain things can help depoliticize because I feel like sometimes when we talk about firearm injury prevention, people just automatically assume you're taking a political stance. But if you're presenting evidence base, it kind of will help to level the playing field there. My next question is for both of you. Let's get like really specific now. What are some examples of culturally competent language that we can like take with us when we're talking to patients about firearms? Should we say like firearms? Should we say guns? Does it depend on the region and who we're speaking to? Things like that.
Yeah, I think it's kind of nice to be able to sometimes hear somebody else's script, right? I know as a medical student, it was always helpful to me to be like, how does my attending ask that question? That's a hard question. How do they ask it, or how do they frame, a certain topic? And so, it's going to be individualized, the language we use, and I think it's important always to make sure we read the room. So what's the right word? Firearm versus gun? Well, maybe we're going to mirror what the patient says, because how they refer to their firearm or gun might be the language they prefer. I tend to lean towards firearm when I'm talking about this, because I think that is, as we're doing research, that has been more of a preferred term, and maybe has a little bit less of a negative connotation for some. So it feels to me more neutral. For others, that might not be the case, but to me, that's what kind of rings true. And so that's how I tend to talk about this. If I say firearm and the patient isn't clear, I'll say gun to make it really clear. Oh, okay, gun. Yeah. Um, and that part is also just understanding kind of when you're talking to someone, if they appreciate what you're actually saying. And then I have a couple of ways I like to ask this. And my couple of go-to questions are, I assume with presumptive language, the person who has a firearm has a plan. So I ask, do you have access to firearms? The person says yes or no. And then I say, what's the plan to prevent unauthorized access? So I presume a plan. I'm presuming safety planning and that it's a secure storage. And then we have a chance to talk about it. And then I'll say things, because suicide is actually a really big thing we need to talk about. I practice medicine in the state of Wisconsin. Over 70%, 70% of firearm deaths in Wisconsin are suicide. As a family doc, I'm seeing people all the time for their mental health conditions. I treat depression. I'm often the first point of contact for things like mental health and depression. And so we got to ask questions like, hey, have you ever thought about, if you're in a time of mental health crisis and you didn't feel safe with your guns in your house, or your firearms in your house, what your plan is? Or I'll ask, have you ever thought about who would hold your firearms for you if things just weren't quite right? I had this conversation yesterday in clinic with a patient, and he's like, actually, my guns are good, but you know what? My brother-in-law, he just got diagnosed with Alzheimer's, and he has an arsenal. And he's like, I'm glad you brought this up. I think I need to talk to him about what our family's plan is going to be with his firearms. Because a day is going to come where he probably shouldn't have access to it, or to them. And it was this amazing moment. It's like me and this like Harley guy with like his big Harley, and I'm not trying to stereotype somebody, but the kind of person you feel like might push back against you if you just looked at the surface. But when he knew I cared about him and we're having a conversation about his family, he felt nothing but joined and was like, man, I got to do this. Thank you so much. And I gave him a bit of scripting. I just said, hey, maybe you just say like, I'm wondering if we could just talk about a plan to make sure, if you're not okay with your guns, who could hold them, or who could maintain kind of the code to the safe, or things like that. And it was a pretty cool solution in that it didn't involve me, didn't involve the police, didn't involve anybody being in trouble. It just involved the family moving towards their loved one.
That's powerful, James, and I appreciate that. I do think, as you said, context matters, and um and if it and we're fortunate in that our nurses do a screening for all the patients that come through the emergency department, and then it whittles down to those that have some particular risk, and it is inquiry. It's inquiry without judgment that is extremely helpful in getting to the core of what we want to know. Is that gun stored safe? And it's not easy, I will admit, by any means, but and we're fortunate to have some resources in place so that if folks do say that, um, then we're able to offer some resources and in some instances provide some behavioral health counseling of sorts. But I do agree context matter. I also want to bring it up a notch in that there is there are policy implications and there is science that has proven some gun laws do make a difference in different states. And so I I would ask this group, that's one of my asks, is that we explore how we can support the development of those gun laws. And it's not imposing, as James said earlier, we're not trying to take guns away by any means. I think you brought up the something I have a dear friend who's a single woman of color, lives alone, a professional. Her home was invaded twice. And the response by friends and the police was to get a gun. And in that moment, my response, it's just how do you respond to that in some instances? It's a safety thing. And so the response is if this is a route that you're going to go down, is please make sure that you get the appropriate training, as James mentioned, on how to use it. And then as important, how you store it. That those are just key pieces because sadly, there's some unfortunate things that are happening in the world, and there are different means by which people take to feel safe. And our advocacy is around making sure that in addition to them making themselves feel safe, is that if there's a gun involved, that there's safe storage involved with that. But I would ask and advocate that we also look at where we can have influence around policy and where the science tells us how, bans, junk gun bans, and also age limits in purchasing and background checks, how all those things and combinations of those things really do make a difference. And I think we have the voice to make that difference. So I do ask for support in looking at those laws that don't take away gun rights, but do make a safer country.
Yeah, I think that's important because the data shows actually the bulk of folks who own guns are never going to do something bad with the gun by a vast majority. But if we can put into place policies so that someone who has a bad intention is not able to actually access a firearm, that's important. So things like a waiting period when someone's in a moment where they're thinking they want to hurt somebody, there's good evidence behind that. And making sure we have exactly age limits and other things put in place is really important. I think sometimes the pushback becomes people say, well, the criminals don't follow the laws anyway.
Mm.
And I don't know if we have enough time to unpack that one, Ted. We
Yeah,
can maybe have a beverage later and talk more about that. But the idea is we need to have some policies in place
we do.
so that we can have the structure to at least prevent a subset of folks who really shouldn't have access. And those would be people we all would agree should be unauthorized to have them. They're going to do something to harm somebody else with a firearm to a person. I think most of us would agree in this country, regardless of the politics of it, we should be limiting access. And that's what the laws in most states say, but actually having them have some teeth to them being enforced is a totally different thing. And that's why I think having evidence-based policies is important. I would echo exactly what you said, Ted.
Thank you both, and that actually leads perfectly into our last question before we turn over to some questions in the chat. Dr. Corbin, what are some opportunities that we can offer our patients to reduce their chance of harm by firearm? And what are those options, something that SAFE works on?
Sure. There's some very practical tangible steps we can offer patients. At the individual level, we can counsel on safe storage, as we've been talking about, including the use of cable locks and firearm safes. We can also connect patients to concealed carry education courses, something else that we talked about, and where appropriate, reinforce responsible ownership and safety practices. Through SAFE, our organization, we're working to make these resources more accessible. And one example is the Firearm Safes and Locks project, which several SAFE chapters, including Rush, that I'm proud to say, are actively piloting. And this initiative helps connect individuals directly to safety devices and education. And importantly, it's something that anyone can participate in, whether or not they're part of a SAFE chapter.
Thank you. And I believe Allison is putting some links for you guys to look at the resources that Dr. Corbin was talking about. We do have some few moments to answer some questions, so I'm pulling some up right now. One question here says, as a pediatrician, I have found it easier to connect with other pediatricians for firearm injury prevention, but harder to connect across disciplines and in more rural areas of my state. Do you have any advice for how to form and sustain broader coalitions for clinician-based firearm injury prevention?
Yeah, we kind of live these siloed lives, right? We live within our specialty sometimes, and I think that's in my experience. I found just trying to ask honest questions about who else is in this space, who else is doing some of this work, how can we share resources, and being really generous in sharing the things I'm doing, and then asking others to teach me about best practices that they found, and it's kind of like building relationships, really. And so I'm a family doc, and I'm like one who was like unnaturally born into like our pediatric injury prevention group because I'm not a pediatrician, though I do pediatric care. And so there's something about being in a shared space, having kind of the momentum of the work carrying us in a similar direction where I've had a chance to have some doors open. And then I think it's helping link other folks up and do some of that networking. And maybe it is facilitating something like a monthly call or a quarterly call for a group of folks who care for patients within some sort of a geographic location, or maybe based on your health system. I've actually done a lot of work reaching out to all of the various health systems in Madison to ask if I could give a talk to their provider group, because I don't think UW Health should be the only place in Madison, Wisconsin where we talk about this, because we have other health systems. And so there's something about that as we reach out sometimes. We get a yes back with a chance to make connections, and um, it takes time, and it's going to take some resources, but I think when you build on some success together, it can go further. You may also have, like in your county or elsewhere, in the state where you're practicing, there may also be like an injury prevention group, or like a trauma um, group, that like the state trauma group, that could potentially be a central point of contact as well. That also is something to think about. When we give out cable locks, we often have them given out through kind of those sort of a coalition of partners. Ted, what do you think?
Yeah, I agree. Networking is key, and I think there are instances where you feel like an island. I would offer up SAFE as one of those spaces, and then there's networks beyond us. There's the Health Alliance for Violence Intervention, who has a cadre of professions that go beyond medicine, are into law and social work and other disciplines, because we know that this is not this affects everybody, and where we're on one end of being providers to our patients who might experience it, or we're concerned about them in some capacity, there's a host of others that are involved in this work, and I would encourage us to partner with them as best as we can. But I do recognize how sometimes you do feel like an island in this work, but you're not crazy. I know I've felt that a lot of times when I'm talking to some folks. But when you find your colleagues and your people who confirm that you're not, and that the work is really important, um, then you'll continue to that'll fuel you to do more.
Yeah, Ted, that's a great point. I think the what you just had to say there about really realizing we need to move towards each other, because sometimes we do feel isolated and alone, and it's big work. And SAFE really does want to be a resource for folks, and a common point of contact. Not that we have it right or that we're the only one, but just so that we can help kind of cultivate the relationships and the connections. At some level, it's not about getting credit for any of the work that's being done. We just want to see the work getting done,
Exactly.
because the stakes are too high.
Absolutely right.
Thank you. Our next question is, okay. Was there a moment where your approach changed when talking about firearms with your patients? When did it go from political to apolitical for you?
I would say in the clinical setting, it's for me, it is always apolitical. It's really about ensuring the safety of our patients. Now, outside of that, it sadly it is political because I won't speak out of turn, but we're in a space where there are certain things that are happening that are going against what we've already built up. So, but I would say in the clinical space, it has always been political. For me, it's always been apolitical because it's really about non-judgmental space for the patients so that we can connect, we can understand, um, and work with them so that we can ensure their safety.
Yeah, I think there's a good distinction between something that's become politicized versus
Mhm.
political. And a lot of healthcare topics become politicized because someone wants to influence it. But when it's within the realm of public health, population health, keeping people safe, harm reduction, as a family doc, I politely say it's actually all my business because it's actually what we do. We care for whole people and we care for them in the communities where they live. And so it's a lot more than just a medication I'm prescribing. We should be talking about things like access to housing and transportation. And do you live in a food desert? Tell me about the access you have to, fresh fruits and vegetables. We should be talking about seat belts and water safety and firearms. It's all right there. It's all part of just the care we provide. And if someone wants to beat a drum saying we're being political, that's their prerogative. I've had patients push back and say I'm being political. And then when I reframe it and sort of say, how would you feel if I talked about seat belts? They sort of were like, what? They were a little bit like, oh, okay. And we just unpack the fact that it's not about coming to take something away. That's the politics. It's about keeping you and your family safe. That's care. That's what we do. That's medicine.
Well said, and I feel like that kind of goes into the next question from the chat. And you kind of touched on this earlier with that story you told. But the comment is, I'd love to hear 1 to 2 memorable stories where you felt like you or your team had a successful communication, or alternatively, a situation where it could have gone better.
Let me tell you my ultimate worst case scenario. There I am, and I bring up to the patient, I ask him about his firearms, and he gets super mad and he says, I'm being political. And it's me in the room. I have a scribe on my phone, and the guy gets so mad. He's like, I'm not talking about it. You're being political. I'm like, I'm not being political. I care about you. He won't hear it. He is just triggered. And so I pumped the brakes and said, hey, we can do anything else you want to do right now. We don't have to talk at all about your firearms. And he said, great. Please refill my medications for me. I want a new PCP. I said, that's fine. That's your choice. And then I facilitated a refill of his medications, asked if he wanted to do anything else. He said no. And then he went out front and got himself a new primary care provider. And then my scribe was like kind of like a little bit freaked out. That was like I asked this of like everybody. As part of my social history, I actually talk about firearms. I ask about tobacco, alcohol, recreational drugs, sexual health concerns, and then guns. Actually, go in that order because I found that asking about firearms is the most intimate question I'm going to ask. And so all day, every day, I'm asking these questions. My scribe was like shaken. She was kind of like, oh my gosh, that was kind of scary. And I'm like, you're on the phone in South Carolina. I'm here in the room with the guy. And you know what I did? I walked into the next room and I went right back to it. Same social history. Asked the same question because it's my job. If I care about people, I'm going to keep bringing up the things that are going to be important as far as harm reduction. And sure, that was a moment. Maybe I could have read the room a little bit differently. Maybe there's a different way I could have framed it. But honestly, people are going to react the way they react. I would encourage folks to not bring something up if they feel like there could be a risk of harm to them. I tell my learners all the time, please, if you're not feeling like it's an okay or safe space, don't go there in that moment. Come get me. Let's do it all together. Because physician care is important. We can't just put ourselves out there and risk harm. But people are going to do what they do. And they might react this way when you ask them about something else triggering, like their alcohol consumption, maybe some other, exercise practice, how they eat, you choose. But the key is to be an observer to the person's behavior, to show compassion, not take it personally. I had best of intentions. I wasn't being political. I was caring about this guy. And he made a choice. If he wants to come back and see me, guess what? I'm happy to see him. Bring him right back. I'd probably ask him the same question again, but maybe I'd ask him, hey, how could I do that differently next time? I might actually just be curious and say, hey, it didn't go so great last time. We might actually laugh about it, I would imagine, because it was awkward. How could we do it differently? Could you teach me about how I could do a better job of helping you think about how to reduce the risk of harms for you and your family with your firearms? That posture of actually letting the patient teach us sometimes is the most humbling approach, and it may get us the most traction when it is the most heated moment, is what I found. Kind of takes the air, that negative energy out of the room a bit, and we take that posture of letting the patient teach us. Ted probably only ever does it right, so he'll tell you a story about how it goes. Goes great when he
No,
does it, but
I wish I could, but in our environment, we have a slightly different environment in that it's a little time consuming. I'm time restraining, and so even when we did one initial push of the pilot around um, distributing gun locks, we were intentional not to do any surveys. The thing that we wanted is, would you like a gun lock? Simple answer. I think in an 8 hour span, we can see anywhere from in 8 hours, there's probably about maybe sometimes we get 15 patients that register in an hour, right? In that 8 hour span, we only were able to distribute 10 gun locks. And so it's not always the easiest, but at the same time, when announced and someone kind of secretly walks up to you and says, "Did I hear someone was offering gun locks?" Then there's an opportunity for some education on how to use it and just give it to them. So it goes both ways. But again, the end game is really making sure that we can distribute them, they understand how to use them, and hopefully that they inevitably use them.
yeah, we have cable locks in our clinic, and we have embedded behavioral health, and so they're kind of a collaborative care piece of our clinical care.
Mhm.
So they extend kind of the clinicians by providing mental health care as well. And we did some training for the behavioral health folks who were right there in the moment, talking to patients about, the safety plans. And I love it when one of the behavioral health clinicians walks up and says, "I just gave out 10 cable locks." I'm like, cool. There's no magic number. What and they were like, "How many should I have given?" I was like, "How many guns did they have?" She said 10. I said 10 sounded good. Nine wouldn't have been enough, you know. And she kind of had a big smile because she felt empowered to actually do something. Of course, we should follow up and make sure that the plan was put into place, and that's important. And maybe there's something besides just a cable lock. Maybe there's going to be a lockbox or a small safe or things like that. And that's part of also where we meet the patients where they're at as far as their needs go. So. But yeah, it's showing up, and what they need is what we provide. No judgment. And I actually say the same thing for my colleagues. If we have colleagues who have firearms that aren't secured, take a cable lock home. Go for it. And I'm happy to know that actually some of the securing devices that we offer for free have gone to the homes of people that I care about who are my colleagues. That's great. That's a win. That's making our community safer. It's not just about the patient I saw on my schedule. It's about all the homes around us having those firearms kept in a secure fashion.
Sure. And the other thing that's true is I'm not sure, but I think for most state departments of public health, they will give you a large box or a large number of gun locks or cable locks for free. You just describe what you're going to use them for, and they'll usually distribute them to you.
Well, Thank you both for sharing those really great stories. Dr. Bigham, I felt like I was in the room with you when you were narrating that first one. But thank you guys so much. We were so honored to have you guys share your time tonight, and it's super exciting to see the momentum that SAFE is building, along with ally organizations across the country. Before you guys go, I'd like to ask everyone to consider supporting SAFE with a donation. We're going to throw a donation link in the chat right now. We're doing really important work that is unique to this space, and we want to hire additional staff to support and build this momentum. Thank you for considering. Another link in the chat also with some immediate steps that you can do to become involved with STAFE will also be dropping in the chat right now. We all know that this is very difficult work and it doesn't feel like something that we should have to do, but it feels like we advocate for our patients and our family every day. We shouldn't have to give money or go to events about firearm injury prevention. We shouldn't have to lose patients on the operating table or to suicide. So with that being said, thank you all for being here tonight, and especially thank you to Dr. Corbin and Dr. Bigham. We really, really appreciate your time tonight.
Yeah, thank you all so much. And I would just say one next step might be let's all stay in touch. We all have a shared interest. We all have work to do, and it's going to take many of us. Together, I think we can provide that uplift to make a big job, maybe something that's more bearable to manage. And so I'm happy to be contacted, and I'm going to speak for Ted too. We're happy to be contacted. If you have further questions after today, if there are things we can do to help, I'd be happy if the place where you practice would benefit from grand rounds or just having a discussion about even thinking strategy. I'm sure Ted would offer this as well. I'm offering up a lot here, Ted. Sorry. But I think we'd
I'm
be
with you,
happy.
James.
We'd
All
be
good.
super happy to just be really generous with some of the things we've been working on. Not that we have the only answer, but we think we're able to help, and we want to learn from you as well. And so it's as much, please reach out so that we can gain from your insights as well.
I echo James' words, and so anything that we can do to support, because it is going to take a village to make a difference.
Absolutely agree. And actually, on that note, I will be at Children's National in Washington, D.C. if anyone's in the area on June 5th, distributing gun locks myself for Wear Orange Day, if anyone would like to join me. On that note, I hope everyone has a great rest of their week. We look forward to staying in touch with Scrubs addressing the firearm epidemic. So everyone stay safe. Thank you.
Thank you,